This is December Orlando GI Journal Club from Orlando, Florida. So our first study is routine molecular profiling in both resectable and unresectable pancreatic adenocarcinoma. We're looking at the relevance of cytological samples, and this study was published by Obeticholic et al. In CGH. 80% of patients with pancreatic adenocarcinoma have locally invasive or metastatic cancer at the time of diagnosis. And pancreatic adenocarcinoma is characterized by 4 commonly altered genes, KRAS, PT53, CDKN2A, and SMAD4, and the possibility to treat homologous recombination DNA repair pathway has been recently discovered with homologous recombination DNA-targeted agents. Therefore, detection of molecular alterations that can be targeted by specific therapies, known as actionable mutations, can improve outcomes in pancreatic adenocarcinoma. The aim of the study was therefore to evaluate the performance of next-generation sequencing analysis on formalin-fixed paraffin-embedded surgical specimens and FNA samples using commercially available targeted DNA panel. So this was a retrospective study at a single institution in Milan, Italy, performed comprehensive genomic profiling by targeted next-generation sequencing in 2 pancreatic adenocarcinoma cohorts. Cohort 1 comprised 77 patients with resectable pancreatic adenocarcinoma with resection sample available, and 56 patients in whom US-guided final aspiration cytological samples were performed at the time of diagnosis. And cohort 2 were 20 patients with unresectable pancreatic adenocarcinoma in whom EUS-guided final aspiration of cytopathological samples were available. So EUS-guided final aspiration was performed using 25-gauge FNA needle, and on average, per the authors, 2 passes were performed and rapid on-site evaluation was available. So for cohort 1, for patients with resectable pancreatic adenocarcinoma, complete concordant mutational profile between a surgical specimen and FNA cytological sample specimen was observed in 88%. KRAS, TP53, CDKN2A, and SMAD4 were the most altered genes, and clinical actionable mutations were identified in 20% of patients. Next, cohort 2, comprehensive mutational profiling was obtained successfully for all FNA samples. And again, in cohort 2, KRAS, TP53, CDKN2A, and SMAD4 were the most altered genes, and 15% of patients had actionable mutations. The limitations of this study is the small number of FNA samples in the unresectable group, which was only 20 patients, and the authors note that molecular profiling could not be performed in all patients due to insufficient FNA quality and quantity in the FNA sample. For example, 4 patients in cohort 1 had sequencing of histological sampling failing. So the take-home point from this study is that comprehensive evaluation of pancreatic adenocarcinoma mutational profile using targeted next-generation sequencing analysis is feasible in clinical practice. The use of formalin-fixed paraffin-embedded surgical specimens and cytological samples allowed for an accurate molecular profiling with 15 to 20% of actionable mutations detected, regardless of disease resectability, and thus offers the possibility of therapeutic strategy. Our second study is by Fiorella Murillo-Perez et al., published in Gastroenterology. It's looking at transplant-free survival in patients receiving obeticholic acid for PBC in a clinical trial setting. Primary biliary cholangitis, it is now known as PBC, is an autoimmune cholestatic liver disease characterized by progressive destruction of intrahepatic ducts, leading to cholestasis, inflammation, and fibrosis, requiring liver transplant in its end stage. First-line therapy is ursodeoxycholic acid. However, 40% of patients on urso experience inadequate response and require second-line therapy. The only approved second-line therapy available for patients with PBC not tolerating or failing ursodeoxycholic acid is obeticholic acid, or OCA. The aim of this study was to evaluate the time to first occurrence of liver transplantation or death in patients taking obeticholic acid versus no obeticholic acid. So this is a comparative study, and they used a combination of data for comparative purposes. The arm in which patients were taking obeticholic acid were patients from the POISE randomized trial. And in this trial, the patients who were receiving obeticholic acid were continued treatment, and the patients who were assigned the placebo were crossed over to the OCA arm at the end of the follow-up period, and then followed for several more years. And then the control arm, patients not on obeticholic acid were drawn from the global primary PBC, the global primary biliary cholangitis registry and the UK PBC registry, and patients were followed up to 6 years. The primary outcome was all-cause mortality and need for liver transplantation. So these were the baseline characteristics. They had 209 patients on obeticholic acid, and they had 1,381 patients and 2,135 patients in global PBC and UK PBC registries, respectively. And the combination of around 3.5 patients is your placebo group, or no obeticholic acid group, and 209 patients is your OCA group. And these were the characteristics. As you can see, there's comparable percentage of patients with cirrhosis at inclusion, with mean ages of around 50, of between 55 to 60. Transplant-free survival, when the authors looked, they found that patients undergoing liver transplant or death during follow-up were 5 in the obeticholic acid group. So this is known as the POISE patients from the POISE data who are on the obeticholic acid, and there was around 135 patients. There were 135 patients undergoing liver transplant or death in the global PBC cohort, 281 in undergoing liver transplant or death in the UK PBC group. And when they compared in this Kaplan-Meier curve the probability of survival and plotted it, they found that the external control, so patients in the global PBC or the UK PBC group not taking obeticholic acid, were more likely to have the outcome of liver transplant or death with hazard ratio of 0.29. In patients in the global PBC group, in patients when they compared the obeticholic acid patients in the POISE trial with patients not taking obeticholic acid in the UK PBC group, again, they found statistically significant higher risk of undergoing liver transplant or death in the external control versus POISE. When they included as an endpoint or outcome measure time to hepatic decompensation to the need for liver transplant or death, again, patients treated with obeticholic acid had significantly greater event-free survival compared with no obeticholic acid, with hazard ratio of 0.42. The limitation of this study is that this is not a randomized trial. This is a comparative analysis of data pulled from 3 different sources. There's a possibility of bias. There is also limited information on the dose stability of ursodeoxycholic acid in the UK PBC cohort, and therefore it is not possible to rule out ursodeoxycholic acid as a potential confounder in this particular cohort. The take-home point from this study is that PBC patients treated with OCA had significantly greater transplant-free survival than comparable external control patients who have inadequate response to or intolerance to ursodeoxycholic acid. The results of the study support the continued use of long-term OCA therapy to optimize prognosis of patients with PBC. Our third study is looking at oncological outcomes after piecemeal endoscopic mucosal resection of large non-pedunculated colorectal polyps with covert submucosal invasive cancer. This is by Gibson et al., published in Gut. Piecemeal endoscopic mucosal resection of large non-pedunculated colon polyps greater than 2 centimeters in size is now the first-line therapy recommended by major society guidelines. But you can have some mucosal invasive cancer following EMR in the sample resected, and that's detected in 5 to 7% of cases. Inadvertent removal of large colon polyps with submucosal invasive cancer can occur, and this is known as covert submucosal invasive cancer. And this is when you remove a large polyp, not realizing there is cancer hiding there, with positive literature to inform treatment decision in this area. The aim of this study was to determine surgical and oncological outcomes in patients with covert submucosal invasive cancer treated by piecemeal EMR. This was a prospective observational study of patients undergoing colonic EMR for large non-pedunculated colon polyps from 2008 to 2018. Over this 10-year period, 3,372 patients underwent EMR for large non-pedunculated colon polyps, and 225 of these patients, at 6.7%, contained submucosal invasive cancer, and 143 patients with covert submucosal cancer were included for analysis in this study after excluding patients who underwent surgery because they had overt submucosal cancer, or IBS-D, en-bloc resection, etc. So out of these 143 patients with covert submucosal cancer who were found to have submucosal invasive cancer following piecemeal EMR, 109 patients, and 109 of these 143 patients underwent surgery. Complete data were available in 98 of these patients, and on a follow-up, they found that 62 of these 98 patients had no residual malignancy on surgical specimen, and 36 had residual malignancy. Of these patients, 5 patients had lymph node metastases. The authors also compared patients who underwent conservative management and those who underwent surgical management in these in this cohort of patients with submucosal invasive cancer, and they found that there were some features which differed between these two groups. For example, patients who had surgery versus conservative management were significantly younger. They also were had lower ASA scores. Greater proportion of patients were ASA 1 to 2 rather than 3 to 4. Also, the depth of submucosal invasion of SM2 or 3 was significantly greater in those undergoing surgery. Also, patients who had R1 involvement underwent surgery, and then the extent of invasion was multifocal in a greater proportion of patients who underwent surgery. Also, as you can see, patients who had poor differentiation were seen in 9% of the conservative management group versus 22% of surgical management, which was not statistically significant, but lymphovascular invasion was found in 3% of patients undergoing conservative management versus 23% in the surgical management group. So these authors then looked at risk factors for lymph node metastases and residual cancer in resected specimen. And they found that the risk of lymph node metastases was significant in patients who had poor differentiation of the cancer on resected specimen, on EMR, and lymphovascular invasion. And therefore, from this study, the authors found that the risk of lymph node metastases when both poor differentiation and lymphovascular invasion was present was 36%. Risk of lymph node metastases when there was no poor differentiation or lymphovascular invasion was very low, at less than 1%. And the risk of residual cancer without poor differentiation, lymphovascular invasion, and a negative margin, RO margin, was also less than 1%. So the authors then proposed an algorithm to risk stratify patients with covert submucosal cancer following piecemeal EMR. And generally, they recommend that if your patient, after performing a piecemeal EMR, is found to have covert submucosal invasive cancer, the first thing you should do is assess for lymph node metastasis risk. So looking at the presence of poor differentiation in the sample or lymphovascular invasion, because that increases your risk of lymph node metastases to 35%. These patients should undergo surgical resection. If they are then noted to have residual intramural cancer, because there is involvement of the deep margin, there is a 55% risk of having residual intramural cancer, in which case they should be assessed for suitability for surgical resection to see if the patients are fit for surgery, and then undergo surgical resection. So overall, if they have no lymph node metastases risk, i.e. they don't have poor differentiation and they don't have lymphovascular invasion on the resected sample, and your margins are clear, risk of having residual cancer is very, very low. Limitation of this study is that histological interpretation was not possible in all patients, and there is some incomplete analysis in the 109 patients who underwent surgery due to missing data in about 10% of the surgery cohort. So the take-home point from this study is that the majority of patients with large non-pedunculated colorectal polyps with covert submucosal cancer following piecemeal EMR will have no residual malignancy. The risk of residual malignancy can be ascertained from presence of poor differentiation, lymphovascular invasion, and an R1 deep margin. Our next study is a double-blinded, randomized, placebo-controlled trial of Enterosgel for the treatment of IBS with diarrhea. IBS with diarrhea is a common but challenging condition with resultant poor quality of life for many patients. Enterosgel is also known as methylsiloxane polyhydrate, is an over-the-counter intestinal absorbent that sequesters harmful molecules, including bacterial products and bile acids, and is safe and effective in patients suffering from acute diarrheal illness. The aim of this randomized trial was to look at the safety and efficacy of Enterosgel in patients with IBS diarrhea. So this was a randomized trial, double-blinded, placebo-controlled, and they included patients who met the IBS-D diagnosis per Rome 4 criteria. Patients were randomized to the Enterosgel or placebo. Placebo was a diluted version of Enterosgel. Patients were followed up for 8 weeks. The primary outcome was proportion of responders on a composite abdominal pain and stool consistency score for at least 4 of the study period, 4 weeks of the study period. So 221 patients were assigned to placebo, 219 patients to Enterosgel. The median age was 44 in placebo and 40 in Enterosgel. The majority of patients were female, about 73% in each cohort. The abdominal pain score, median was 5.1 versus 5 in the placebo versus Enterosgel group, and days of at least one stool of BSFS 6 or 7 was 4.4 in placebo and 4.4 in the Enterosgel group. So then they looked at the responder rates for composite of abdominal pain and stool consistency. And the authors found that patients in which they found an improvement in stool consistency and abdominal pain was significantly superior in the Enterosgel group of 37.4% versus 24.3% in the Enterosgel group versus placebo, which was statistically significant with odds ratio of 1.95 and p-value of 0.002. When they looked at just improvement in stool consistency, Enterosgel was again superior to placebo with a proportion of responders of 58.4% versus 42.5%. When they looked at abdominal pain scores, again, it was superior in the Enterosgel group versus placebo with odds ratio of 1.8 with p-value of 0.0034. This is looking at other symptoms and secondary outcome measures in these patients in this study. And as you can see, apart from very, very few variables, looking at it, none at all, Enterosgel seems to be effective in improvement of all of these IBS symptoms when compared to placebo, including stool consistency, abdominal pain, stool frequency, bloating, urgency, and need for loperamide. Adverse events encountered included nausea, abdominal pain, bloating, constipation, headaches, dry mouth, back pain, and loss of appetite. But as you can see, the incidence of nausea, abdominal pain is very low and looks comparable between Enterosgel and placebo, with the highest adverse event being nausea, occurring in 3.8 in placebo versus 3.7% in the Enterosgel group. The limitation of this study is the generalizability of the study results, because patients not meeting Ring 4 criteria were not enrolled in this study, and it's impossible to replicate treatment drug exactly with the placebo, and that is an issue encountered on all placebo-controlled trials. It does say in the study that they did try and exclude patients in whom they may have used Enterosgel before and therefore may recognize what the medication is like versus the diluted version that they use for placebo. And then flexible treatment instructions were used in the study with incremental dosing pattern. And so the authors are not able to establish a set dosage scheme for maximal treatment benefit. So the take-home point is that Enterosgel is safe and effective for the treatment of main IBS diarrhea symptoms, and although primary action is on stool consistency, it provides benefit to global symptoms and improvement in quality of life, and provides a valid alternative to the few treatment options currently available for patients with IBS-D. So to recap, comprehensive evaluation of pancreatic adenocarcinoma mutational profile using targeted next-generation sequencing analysis is feasible in clinical practice, and the use of formalin-fixed paraffin-embedded surgical specimens and cytologic samples allowed for an accurate molecular profiling with 15 to 20% of actionable mutations detected regardless of disease resectability, thus offering possibility of therapeutic strategy. PBC patients treated with obeticholic acid has significantly greater transplant-free survival than comparable external control patients who have inadequate response to or are intolerant to ursodeoxycholic acid. The results of the study support the continued use of long-term OCA therapy to optimize prognosis in patients with PBC. Number 3, the majority of cases of large non-pedunculated colorectal polyps with covert submucosal cancer following piecemeal EMR will have no residual malignancy, and the risk of residual malignancy can be ascertained from presence of poor differentiation, lymphovascular invasion, and R1 deep margin. Enterosgel is safe and effective for the treatment of main IBS diarrhea symptoms, although primary action is on stool consistency, provides benefit to global symptoms and improvement in quality of life, and provides a valid alternative to the few treatment options currently available for patients with IBS diarrhea. So thank you so much for joining us again this morning. Our next monthly GI Journal Club is on January 4th, 2023. Thank you again so much for joining us every month for the entire year. I hope to see you every month next year, and wishing everyone really happy holidays, a restful and peaceful end of the year, and a happy new year. Thank you so much.